right for everyone at the right time. What we ask is for everyone to start to think about what's possible. Maybe it's just with your commercial insurers, maybe it's with a small part of your practice, maybe it's just EHR, whatever it is, you start down that path, because we hope that, as you take small steps, the change won't be as dramatic, and hopefully you'll see that it's moving in a direction that's good for your patients and good for your practice.
I'm Logan Wine, med student from Baltimore. The question I have is, we're hearing a lot about the Affordable Care Act and how it's going to expand coverage for many of the uninsured and underinsured. Yet there's one sort of elephant in the room, large population that we're not really talking about, and that's the undocumented folks living here in the States. And so I realize the ACA was largely gutted of the provisions for them, but I'm wondering what provisions are still left in the ACA to provide coverage for undocumented folks living in the United States, and then what steps can we make such that in the future, as we're working on this healthcare reform issue, that we can sort of begin to expand coverage to that population as well?
Well, Logan, I think the reality is we need comprehensive immigration reform. I don't think there is an easy, simple answer here, or measures. Mandy may know a few, but there are not measures here tucked away for this community. And the president has been incredibly clear that he wants to see comprehensive immigration reform, but he would also look at other variations, perhaps a combination of high-tech visas combined with something like the DREAM Act, combined with something like ag jobs, so that, just one area I'm sure many of you see is undocumented immigrants here working in the ag sector, probably dealing with some of the toughest health problems. I think there are advocates in the immigration community who are struggling with difficulty moving this through Congress and want the administration to be able to say, well, we can fix it, but we have to live within the laws that are on the books right now, which we think need changing. But I do see a lot of optimism there, actually. I think you see, while it's not an approach or a policy that we would support, you do see Senator Rubio talking about this issue. I think there's a coalition that's ready to be formed, and the voices of Doctors for America and others in the healthcare community could be an enormous part of getting it done.
My name is Heidi Foley. I'm a family physician from Massachusetts. I'm not sure if these are questions, but more that I need to hear some reassurance. The first is on EMRs. The next 3 or 4 years, we actually do have some money coming in to help us with transitioning to EMRs. But after that, I still have to pay my EMR 11% of my income every single year. That's a lot. And then you add billing to that. Where are we going to go? The family docs can't carry that. I'm a single doctor in the practice, and that's a lot off my shoulder. So where are we going to go in the future where it's not the doctors that are covering the cost of the EMRs? And the second is, I'm participating in the Patient Centered Medical Home Initiative in Massachusetts. And what's expected of me, and the number of people I've had to hire to get all of the work done, is unsustainable with what we're being paid, the incentives we're being given. And I don't know that people are hearing that in Washington. But until you actually pay me to hire an RN, the only place it can come out of is my back pocket. And I'm already one of the least paid doctors. Well, we are. Our specialty is paid the least of anybody. And if you don't hear that, all we're going to do is keep losing docs. Because if you want us, we're doing great things. I think it's wonderful things we're doing in the initiative, but it's just unsustainable with what we're being paid to do it. So they're not really questions. I just need to hear some reassurance.
Well, first, congrats for taking on both electronic medical records and being part of that pilot. It's an important, as you're saying, we are testing these. And I'm hoping that you're feeding back this information to those that are running, and as you're speaking, we need to know where's the right set point for the things that we're pricing out. Because we really haven't, as a payer, at least CMS has not said, okay, how much does comprehensive primary care cost? Like, what should we be paying in order to make you whole? And so I don't know that we know the right dollar amount. So these tests are really important. Some practice will be very successful, others won't, and we need to understand why and how to make it sustainable. So we are learning. So feedback exactly as detailed as much as you can to those folks, and feel free to get in touch with me, and I'll put you in touch with the folks that are working on our comprehensive primary care work, because all of these lessons are very valuable. Because if we don't learn them now, we're gonna move on and assume that things are working, and we're gonna roll in a good way. We think they're working, we'll roll them out. So we need to learn as quickly as possible. So, I'll just reiterate, bring stories to whether it's, Doctors for America or through other channels to make sure that we can continue to hear the concerns that you're experiencing in your practice, because they're very real.
I'm Mel Stern. Are you here? I'm Mel Stern. I'm a pediatrician from Maryland. Two questions. One, actually I'm a little confused. When we talk about risk and assumption of risk, insurance for years has been the province of individuals who were assuming risk and expected to make a profit by reducing that risk and being able to keep the remainder. We now have on the boards ACOs, which it's been said many times today, that they're going to assume some of the risk and manage that risk. Can you explain to me and clarify exactly how that distinguishes itself from the previous HMO concept, which basically was the same thing, where we had originally nonprofit organizations that were put in place or supported by the federal government to assume risk, reduce that risk, and be profitable as a result of that. The ACOs seem to be moving in that direction as well. That's my first question. My second question is, absent the pediatric Medicaid population, what do you see CMS doing in supporting the rest of the pediatric world in making sure that kids aren't left off the radar screen?
Great questions. So the first one, the first about accountable care organizations and risk. So as I mentioned, we're testing a lot of different types of accountable care organizations, and there are some accountable care organizations that we are testing that have no risk to the provider. And when we're talking about risk, for those of you who don't, this was Greek to me, meaning that if you go above a certain budget that CMS gives you, you have to pay back essentially to the government. And meaning you're taking on the risk to say, I won't go above $100,000 for this X number of patients, and if you go above, you owe us the government money back. So we are testing models of accountable care organizations that have no risk. And in those models, you don't get as much reward because you're not taking risk. So if you take on more risk, you have the potential to get more reward. So it's knowing yourself and your organization on whether or not you're set up to do risk or not. And the way the concept and how this is different, this is a whole lecture and talk, and I'm happy to talk more offline about the theory of accountable care organizations, and I do emphasize again, we are testing. And the way that it is different than an insurance company is this is directly contracting with providers. So you're getting a step closer to the patient and what those patients need, as well as what the local environment is like. So the thought is that an integrated entity knows their patients and knows their population and knows their community better than an insurance company intermediary ever could. And thus, they can take on that responsibility for the population in a different way than an insurance intermediary. And again, I emphasize the fact that patients can go anywhere. So if you think about, if you could go anywhere as a patient, that ACO needs to work extra hard to provide you very good service for you to stay in their network so that they can give you the kinds of services that keep you healthy and out of the hospital and all that stuff. So, I think there's two sides to that coin about how it's different than an HMO. As far as the pediatric world, and obviously this is more on the Medicaid front for CMS, where we don't have as much control as we do with the Medicare side, not just the way that funding works. But you will see also, I briefly mentioned that the Innovation Center is doing some challenge grant awards. And you'll see in those awards that we are focusing more on the pediatric populations because our portfolio hadn't done that in the past, and we recognize the deficit. And so you'll see some interesting pilots come out of, in the pediatric world, come out of that program in a couple of weeks. I can't say more right now.
All right, well, I think we're actually out of time for questions. This hour has kind of flown by. Thank you so much, John and Mandy, for being here and for participating.